Bismillah ar-Rahim. Dear candidates, we welcome you to the Part 1 MRCOG preparatory course. First of all, I would like to thank the Galea Maternal Hospital and Dr. Abdel Shouel, who is the General Manager of this hospital, for hosting this course. We've been actually hosted by the Galea Maternal Hospital for the last almost 6 years, and we thank them for saving us all the efforts and all the facilities to make these courses successful. Secondly, I would like to thank Professor Kamal Abu Sfour, with the honorary chairman of the Egyptian Political Committee. Actually, he has all the credit for starting these courses to be run on a regular basis. The course actually, through the feedback that we had from our candidates through the previous exam, has been successful in preparing candidates for passing the exam. And we can see actually through the previous courses that the numbers of the candidates attending this course are increasingly being able of passing the exam. I wish you all a successful course. I hope actually you'll be among those who are going to make use of it in passing the next setting of the exam. Thank you all for participating, and I will give the phone for my dear Professor Kamal Abu Sfour.
بسم الله الرحمن الرحيم. سيادة الأخ العزيز الأستاذ الدكتور عبد الشواري، مدير عام مستشفى الجلاء، الأخ العزيز الأستاذ الدكتور عمر شقاني, Chair of the Egyptian Representative Committee of the Royal College of Obstetrician and Gynecologists, dear colleagues, indeed it is my great honor to be here with you today in this opening session of this preparatory course for the Part 1 MRCOG. Certainly, the Egyptian Representative Committee, under the competent leadership of Professor Ahmed Shafkani, should be commended for its efforts in continuing running these courses very, very successfully indeed. You cannot imagine how much work is behind this. You cannot imagine how much it is a tedious effort to prepare for such a course. You may stay here for 3 or 4 days during the course, but lots of work has been done in order to make this preparatory course a success. The indications of success of this course is quite evident from the percentage of the people who pass the exam after attending the course. In fact, based on previous statistics, I think the percentage of the people passing Part 1 MRCOG in Egypt is equivalent to those, if not even better, than candidates in the UK. And this has been documented, and in fact, the activities of the Egyptian Representative Committee is one of the leading activities of all committees around the world. So I think you are lucky that you have a very active Egyptian Representative Committee who is caring for its young colleagues, who is caring for the future obstetrician and gynecologists, and in helping them. Having said so, I must admit that the course provides you only with direction and inspiration and guidance to the success. The success depends upon you, depends upon your knowledge, depends upon how much you prepare yourself for the course. The course, how much you prepare yourself for the exam. The course provides only guidance, so do not expect that the course will give you all the information which you would expect the questions will come from it. Indeed, this is not true. It is only a direction for you, guidance for you, so that you are trained on the exam, how the exam is being run, how to make the best of the time during the limited period of the exam in order to spell out correctly all the knowledge which you had gained during the probation period. So indeed, I do wish you all the success in attending this course. Having said so, this course would not have been possible without the cooperation, assistance and support of Al Galaa Maternity Hospital under the competent leadership of Professor Abdel Shouari. Indeed, the fact that the committee had always held this course in this hospital where majority of us senior obstetrician gynecologists got their training in this great institute, this support is instrumental in the efforts of the committee to achieve its objective of its continuing education and training program and in running these courses. So on behalf of the Egyptian Representative Committee, I would like to thank my colleague and my friend, sincere friend, Professor Abdulaziz Shobari, for all the assistance he has been providing for the committee. Wishing you all the success and best of luck, inshallah. Thank you.
Word is from Dr. Abdulaziz Shobari.
الحقيقة أنا بسعد بوجودكم في مستشفى جلاء، وبسعد بوجودي على المنصة جنب الدكتور جمال السرور. يعني الدكتور جمال السرور بيقول عليا كليك، أنا الحقيقة دكتور جمال كان مشرف على رسالة الماجستير بتاعتي، يعني فيعني ده سعادة ليا إن أنا أقعد جنبه على المنصة. الدكتور عمرو الشلقاني هو اللي كليك، الدكتور جمال is my professor. أنا بس شايف في ظاهرة خطيرة. الدكتور جمال هتدونا بتاعي عدد البنات أكتر من عدد الولاد. لو كانوا الام ار سورجين سواء مع الرقم بيطلع. فانا شايف الظاهره دي بتزيد. البنات دول لو خدوا كلهم الام ار سورجين هتقفلوا انتوا تعملوها ليه انتوا بقى. ارجو ليكم التوفيق كله، وان شاء الله هحكوا لنا بقى في التريننج بتاع السكند بارت ان شاء الله.
وتعليقا على كلام اخر زميلي الاستاذ دكتور علي الشجري، انا كنت في الهند في بنجلور، كنت بدعو للانترناشونال ميتنج بتاعت بنجلور سوسايتي اوف اوبستريك جاينيكولوجي. 98% من الاوبستريشن جاينيكولوجيست في بنجلور they were ladies. President of the society was a lady, vice president, treasurer, members of the council. There were only few men and I was one of them. بعدها about 3 weeks ago I was in Muscat, Oman, and I discovered that all obstetrician gynecologists are females and there is not a single male in Oman. The only male there was Professor Haris Lamki as a visiting professor because he originally comes from Oman, and myself. So we were the only 2 men in the whole conference hall. So this is very reassuring.
First of all, we have to understand that we are not meant to comprehensively بشكل شامل وعميق ان احنا to revise all the basic sciences for the MRCOG. And remember as well that the exam is MCQ and the new format containing as well EMQ, which is extended matching questions. You are not asked to write essay questions. This is extremely important, and I think that actually this is a bit easier for you. As I said that we will never be able to comprehensively revise all the basic sciences. So actually, we recruited all the speakers who had been interested in teaching for the MRCOG. Most of them actually are obstetrician gynecologists, and we resorted to our dear colleagues from other specialties. You will notice that there are actually some specialists in clinical pathology, in pathology, and genetics and anatomy. Because still actually we need to have some instructions regarding these basic sciences. Regarding the sources from which you actually need to study, try as much as you can to focus your knowledge. You can spend years and years in revision again of all the basic sciences, but you need to focus your knowledge. So I would say actually that there are 3 essential readings for you. The one from Tim Chart, the late Tim Chart, and the one from Dewhurst, and there is another one actually that has been released, and I think that it is helpful as well. It's for the MRCP. The small text actually for revision for the MRCP. The content of this text actually regarding the biochemistry, regarding the genetics, the statistics in this book are extremely helpful. So you can use the 3 small textbooks for the content that is almost essential for before going into the exam. If you have any queries, you may resort to other textbooks. Never actually start from the very beginning in opening large textbooks. تفتحش ابدا الكتب كبيره في الاناتومي ولا تطلع كتب الاناتومي بتاعت سنه ثانيه ولا ثالثه والباثولوجي والحاجات دي, you will be at at a loss. Don't ever try it. You have multiplicity of books for MCQ, so you need to go through them all. I always say, use them as you are taking your lunch instead of watching. Use them while you are watching the satellite channels. I mean, every day, open the book and look at the types of the MCQ questions. There is, I think, one book only available for the part 1 for the MCQ. I think it's enough to know what it is. You don't have.
It's available.
Yes, it is being copied actually. It's present. This is my advice. Always remember that 60% of the exam is guaranteed because they never change. And what happens actually that we get concentrating on the minute things, the updates, and we forget, for example, that the anatomy has not changed over the last 30 years. The basic sciences for example, biochemistry and physiology hasn't changed for the last 20 years. And you can guarantee the marks of these questions. للأسف بعض الكانديدز بيخسروا درجات من الحاجات اللي هي ما بتتغيرش خالص. يعني anatomical relationships يخسر فيها درجات. Embryology يخسر فيه درجات. Biochemistry, chemical nature of hormones and how does they act يخسر فيها درجات. بنوصل في الآخر there are the 20 or the 15 to 20% which are difficult and they are difficult for all the candidates. And I believe actually that these are not the ones that make a difference between the successful and the failing candidate. مش دول على فكرة اللي بيفرقوا. عادة اللي بيخسر في الجزء البيزك تماما. So please concentrate on these guaranteed marks. As I said, they are around 65% of all the marks of an exam. Okay? These are the topics that are covered in. Of course, you know that the exam is 2 papers. Each one of them is 2 hours. And paper 1 actually is dedicated to the anatomy, the embryology, the endocrinology, the microbiology and virology, the pharmacology, statistics and epidemiology, and clinical trial design and analysis. And actually statistics, epidemiology and literature appraisal or critical trial design and analysis has increased markedly over the last 4 or 5 exam sets. It used to be actually 2 questions and now there is 5 with 25 items. So the contribution of it has increased in the last few sets of the exam. Paper 2 actually is dedicated to the biochemistry and molecular biology as well. Biophysics, genetics, immunology, pathology, and physiology. And you have to remember that actually, for example, genetics with biophysics, molecular and cell biology and biochemistry and proteomics are now interlinked. مفيش boundaries. There are no boundaries between these items. And we tried as well that the molecular biology will be covered in many aspects. So the great majority in this course will be covered through the genetics, and the rest will be covered through other parts like pathology and the biochemistry. The MEQ actually is part of the same paper. So the contribution, you don't have a separate time for the MEQ. So paper 1 would have MCQ questions and would have as well the MEQ questions. And actually the MCQ is being answered in a different paper, answer sheet, and the MEQ questions are being answered in a different answer sheet. The MEQ has been introduced because actually they increase the validity and reliability of the assessment of your knowledge, and they test actually higher levels of understanding. And it has been educationalists, التربويين يعني they can prove in the format of extended match questions actually can test higher levels of knowledge, not only memorizing factual knowledge. It actually uses how to integrate many parts of your knowledge and come up with an answer for the extended matching questions. Usually it have a set of options and then a number of questions afterwards. And through each question, you are asked to choose which of these items would be the appropriate answer. The MRCOG actually would constitute 20% of each paper. Yani 2 papers, and 20% of each paper would be dedicated to the MRCOG questions. This is the older format where we have equal distribution of the number of questions in each paper. We have 300 items to be asked about true or false. The new format actually that you would have 240 items for the MCQ, and you would have 20 items, 20 questions for the MRCOG in each paper. The correct answer for an MRCOG actually would equal almost the marks of 3 true or 3 correct MCQ questions. يعني كل سؤال MRCOG تقريبا equivalent ل3 MCQ من حيث المارك. This is the answer sheet for the MRCOG. Is a bit different for the true and false of the MCQ. So we have, for example, for question number 1, this number of choices. And you need to actually shade. For example, if number A of the choices is true, you are going to shade number A. So in every row, you would have only one square to shade it. This is the example of how it looks when you answer the question. Okay? We go through actually the rest of the course through many. I will concentrate a little bit on the MRCOG questions because it's a newer type of format we are not used to even in our undergraduate teaching in this country. So we'll concentrate actually at the end of each day on how to answer the MRCOG questions. Okay? Any questions?
One correct answer? Only one correct answer?
Yes.
Thank you.
Yes.
And answer
And you will have actually at the ending of the questions, there is only one correct answer. You may use the same answer once or more than once, or you may not use it at all. يعني ممكن كمان يعني يجي كذا السؤال وتبقى الإجابة بتاعتهم هي. It's possible. Okay? Any other questions?
Chart and second source. What is the name of second source?
I'll bring the third one because I can see that it's extremely useful. There's two small texts for the MRCG, the tail chart, and the Dewhurst, the Sweet and Chamberlain, and the third one is for the MRSP, but I find it actually extremely helpful as well in many sections.
MRCP.
Yes, I'll get you a copy. Just see the name of the author.
Professor of Pathology, Unit of Early Cancer Detection and Shanks Maternity Hospital. It's a pleasure for me to participate in the teaching of the course of the MRCG. I hope that most of you have the handout I sent by email. They focus on important points, but if you find that I say something a little bit detailed and you want to add it, it's okay. I will try as much as I can to focus on the topics I received that are important to you regarding, at first we'll begin with the basic general pathology. Okay? We'll start at the very beginning on the focusing on the structure of the human cell. Basic structure of the cell. نعمل animation مع basic structure of the human cell. Here is the cell membrane. It is an active membrane. It requires energy. It allows some things to enter and does not allow other things to enter. Then we have the nucleus, which is the important structure in the cell. And within the nucleus, we have the nucleolus, in which the RNA is concentrated. We have the chromatin that is clumped here at the periphery. And we have other structures in the cell, like the endoplasmic reticulum. Then we have the ribosomes here. We have the Golgi apparatus, and we have the mitochondria. These are the basic structures of the cells. Of course, the mitochondria produces the ATP. The ribosomes, they produce new material in the cells. Next. We have the surface epithelial cell and the glandular cell. The surface epithelial cell has the same structure as we mentioned, the nucleus, the nucleolus, chromatin, we have mitochondria and so on. But the glandular epithelial cell, for example, is like the endocervix. Electron microscopy has shown the presence of microvilli, and then we have the cues that produce mucin. Of course, between the cells, there are the lisosomes that connect the cells together. We come to the first topic. It's what we call cell injury, damage to the cell. We classify the cell injury into reversible damage and irreversible damage. The irreversible damage is the damage that will affect the nucleus. And the reversible damage is that if it affects the cytoplasm, for example, swelling of the cytoplasm as we will take, this can be reversible. But if you say necrosis, because it affects the nucleus as well, the cytoplasm, this is irreversible damage. This is one point in the cell injury. The other things that can injure the cell is deposition of new material, not only in the cell, in the connective tissue stroma or in the wall of the blood vessels. An example of this is amyloid deposition, what we call amyloidosis. Amyloidosis is a deposition of a protein in the connective tissue stroma and in the wall of the blood vessels. It is classified into primary amyloidosis without a cause and secondary amyloidosis. Secondary to what? Secondary to chronic intoxicating diseases. For example, tuberculosis can be complicated by amyloidosis. Syphilis, chronic suppuration in the lung. All chronic diseases can be, the end result will be amyloidosis. By H&E, the amyloid material gives me a homogeneous pink material. Other things can give the same picture by H&E, so we do a special stain. This is what we call the Congo red stain. The Congo red stain, the slide is a little bit faint, but the Congo red stain will highlight the area and will give me a red color for amyloidosis. And this was a seat of an MCQ question in the MRCOG. So whenever I find something that I found by the way, I will focus on it. So the Congo red stain stains the amyloid and differentiated from other deposition like halide material. Both of them, as I mentioned, give homogeneous pink. So for amyloid, you have to do another stain. Next, please. Other change that can occur in the cell is what we call atrophy. What is the definition of atrophy? For example, this is a testis, a normal testis, and this is an atrophic testis. We all appreciate that there is a decrease in the size of this testis. Is it a decrease in the number of the cells or decrease of the size of the cells? It is decrease in both. So atrophy means decrease in the size of the organ due to increase in the number of the cells as well as decrease in the size of the cells. Next. We come to a damage that occurs in the cell, what we call apoptosis. And apoptosis now is becoming very fashionable terminology because it has been incorporated now in the genesis of cancer. What is the difference when we say apoptosis and necrosis? Apoptosis is a programmed cell death. الموت المنظم للخلايا. When I order the endometrium to shed every month, this is a regular death of the cell. When I order the RBCs to be destroyed every 120 days, this is a programmed cell death. Then what's the difference between apoptosis and necrosis? As I mentioned, this is a programmed cell death. This affects the individual cells, not like necrosis, a part of a tissue, a part of an organ. This is necrosis. Okay? The affected cell that will undergo apoptosis will become shrunken and transformed to what we call an apoptotic body. The recent theories for cancer, why cancer, and we have so many theories why cancer developed, but one of them now is that it is a defect in the genes controlling apoptosis. Okay, and it's now very complex genes, newly developed for controlling apoptosis. So this is the live cell, and this one cell that has undergone apoptosis. We come to another material deposited in the tissue is calcium deposited in the tissue. We all know that the normal deposition and normal size for calcium deposition is the bone cavity. Anything else other than these sites is called pathological calcification. We subclassify pathological calcification into dystrophic calcification and metastatic calcification. Metastatic does not mean that this is metastasis. No. What is the difference between these two items? Dystrophic calcification, and remember it with the D, occurs in dead and degenerated tissues. And mind you that the serum calcium level is totally normal. This is an important point of differentiation. So we haven't got calcification here because it's a hypercalcemic state. No. It's normal calcium level, but we had a dead tissue or a degenerated tissue. For example, a dead fetus, a dead parasite. In atherosclerosis, we get calcification. Then why calcium is deposited in these areas? Calcium circulates in the blood. How does it know that this is a dead area and goes to deposit in this area? Take it a rule, calcium favors alkalinity. The dead tissue has an alkaline pH. And this alkalinity acts as a magnet that attracts to calcium and becomes deposited. We come to the metastatic calcification. The condition is different. We have here a state of hypercalcemia, increase in the level of the serum calcium. So it starts to deposit in living tissue. This is another difference, not in a dead or degenerated tissue. This hypercalcemia can be due to hyperparathyroidism, can be due to cases like chronic renal failure, and it deposits, again, normal tissues, but a little bit alkaline pH. Like, for example, around the lung alveoli, around the fundus glands, around the renal tubules of the kidney. So we achieve the difference between what we say dystrophic and metastatic. This is an example of an artery. As you all appreciate that the lumen is narrow, therefore this is an area of atherosclerosis. What about this patch? This is an area of dystrophic calcification in a wall of an artery having atherosclerosis. We come to necrosis. We mentioned a few minutes ago apoptosis. What do you mean by necrosis? Necrosis means cell death during growth. Reversible or irreversible damage. It is an irreversible damage to the cell. This necrosis is accompanied by certain changes in the nucleus. The nucleus can be, this is the living nucleus, nucleolus, chromatin. So we have one of three possibilities in necrosis. Either the nucleus will be like a dark spot of ink. This is called karyopyknosis. What do you mean mean by karyo? Karyo is the Latin meaning for the word nucleus. So we can have karyophytosis, means it becomes condensed chromatin, can be fragmented, so we call it karyocrexis, or you don't find anything in the place of the nucleus, karyolysis. Again, this was a seed for MCQ question. Differences between the three patterns of the nuclear disappearance in case of necrosis. The types of necrosis. What will be the appearance of the necrotic tissue afterwards? We have more than one possibility. Either the necrotic tissue will become firm and coagulated, so we call this coagulative necrosis. Or on the other end of the spectrum, the necrotic tissue will become liquid, so we call it liquefactive necrosis. A midway between both. It's neither firm nor totally liquid. It's a creamy or cheesy material. So this is seen in caseation necrosis. And then we have necrosis of fat necrosis. The coagulative necrosis is seen mainly in infarctions, like myocardial infarction and renal infarction. The liquefactive necrosis is seen best in the abscess. You had a firm tissue that has changed to a liquid. And in brain infarction. Why in brain infarction we get liquefactive and not coagulative? Because of the high lipid content of the brain. When you cut the blood supply, this lipid becomes liquefied. Then caseation necrosis, the best example is in tuberculosis. These are just the appearances of necrosis. See the coagulative? The cells are still close to each other and not fragmented. Here we are. This is the lung with a focus of tuberculosis showing yellowish material. This is caseation. Where in the brain, mostly it becomes liquefied in case of cerebral infarction. This is a fat necrosis. This was the best example for it. Occurs either in trauma to the breast, so we call this traumatic fat necrosis, and this constitutes a problem because your gynecologist, you are definitely facing cases with breast lesions. The patient gets with a hard breast mass that can be confused with malignancy. And another example of fat necrosis is that occurs in the pancreas in case of acute hemorrhagic pancreatitis. With release of pancreatic enzymes into the omentum, especially with the lipase, it digests the fat in the omentum. Who will hurry up to this area? We just mentioned any dead tissue or necrotic tissue, the calcium will be deposited. And we get the omentum firm with chalky white deposits, typical of acute hemorrhagic pancreatitis. We come to the term that has received much attention today, what is called dysplasia. What's the difference between I call dysplasia and neoplasia? This is a healthy cell. See the cells arranged perpendicular to the basement membrane with a normal maturation. When we come to define dysplasia, it is a disturbance in the maturation of the cells. Then why don't you consider it malignant then, if it is a disturbance in the maturation? It is a disturbance in the maturation, but still respecting the basement membrane. If you compare dysplasia here with a malignant tumor or cancer here, this, we have here disturbance in maturation, but we have invasion and destruction of the basement membrane. Another difference, dysplasia will not give you a mass. You will not see when you examine the cervix having dysplasia that you will see a mass in the cervix. No. But in malignancy, you will see a mass. You understand? Therefore, dysplasia is a disturbance in the maturation of these cells. No invasion of the basement membrane. As regards the classification of dysplasia, we'll mention a few minutes later. Okay. Another terminology that will attract our attention, this is a another type of tissue deposition, and another site for MCQ questions next. The deposition of iron in the tissue, what we call hemosiderosis. You know that hemoglobin, when it breaks into heme and globin, and here we have a picture. If we have a state of iron overload in the body, as for example cases of hemolytic anemias, now this pigment will become deposited in the tissue. So we have accumulation in the liver. Accumulation of iron could be due to an inborn metabolic defect, or it could be acquired, like in cases, as I mentioned, of hemolytic anemia, sickle cell anemias, phagocytosis, or in cases of patients having immune reaction to blood transfusion. This is schematic presentation of the situations of iron overload. As I mentioned, either we have excess absorption, this is a genetic factor, or it is acquired. The danger is that we will get deposition in the liver. How can I be sure that this pigment is iron that is deposited in the liver? We do for it a special stain by a special dye. This is what we call Prussian blue dye. Prussian blue is a blue color, but you know the blue color has different degrees. The royal blue, the navy blue, the sky blue, and this is one of the degrees of the blue. Even the painters نقاشين عارفين يقول لك درجة الأزرق أزرق بروسيا. This is the Prussian blue. If you just want to remind it, you can remember Russia and put a P, so it will be Prussian blue. This will give you a blue color. If you suspect that this pigment is iron, please confirm with the Prussian blue action. Again, this was a site for MCQ question. The danger for this iron pigment is that it will enter by cirrhosis in the liver. It can be deposited in the pancreas and give diabetes. It can be deposited in the skin and gives you a fashionable bronze color. So sometimes they call it the bronze diabetes. We come to another change and another pattern of injury to the cell that is reversible injury, what we call hydropic swelling. As the name shows, hydro refers to water. So we have water entering into the cell. As a result, this cell will become swollen and the cytoplasm will have some vacuoles. This change is a mild change and a mild injury to the cell and can be easily reversible. It occurs in the course of some fevers, typhoid and so on, but it is a reversible and mild damage. Next. We come to other terminologies in the cell. We come to hyperplasia. What's the difference when we say hyperplasia from hypertrophy? Both of them, there is increase in the size of the organ. But is it increasing the number or increasing the size of the cells? What do you think? When we say endometrial hyperplasia, do you think the size of the glands increase or the number of the glands increase? It's the number. The hyperplasia is increasing the size of the organ due to increase in the number of the cells. And we have so many examples for hyperplasia. For example, hyperplasia of the thyroid gland, if there is iodine deficiency, for example, we get hyperplasia of the thyroid gland. Another example for hyperplasia, here we are. This is the uterus, and under the effect of estrogen stimulation, we will get hyperplasia of the endometrium. And when the endometrium is hyperplastic, it starts to be thrown into folds, and we get endometrial polypi. Another example of hyperplasia is hyperplasia in the prostatic gland in old age. Again, due to relative increase in estrogen in old age males. Next. Another example of hyperplasia in the warty type of condyloma. We get epithelial hyperplasia and the epithelium start to be folded. we have increase in the number of the cells and not increase in the size of the cells. We come to hypertrophy. The best example of hypertrophy, the definition of hypertrophy is increase in the size of the organ due to increase in what?
The size of the
The
cells.
size of the cells. Excellent. Now here we have the size of the cell. And the best example we see hypertrophy is in the wall of the left ventricle in case of benign hypertension. This is an overload on the left ventricle, so we get hypertrophy in the wall of the left ventricle as well as the papillary muscles. Okay? The wall thickness might reach up to 3 centimeters in cases of hypertension. Yes? We can also have hypertrophy in the right ventricle in case we have lung disease. For example, like emphysema in this lung, this would have an effect on the right ventricle. Any fibrosis in the lung will cause hypertrophy in the right ventricle. The situation that we call cœur pulmonaire, disease in the lung that affected the heart. The end result will be hypertrophy in the right. We come to the term metaplasia. We have to go through these terminologies. They are very basic and very important side for MCQs. What's the difference when we say dysplasia and metaplasia? Because you definitely encounter pathology reports. So what when you say metaplasia? Metaplasia is a change from one type of epithelium into another type of epithelium. For example, the lining epithelium of the bronchus is pseudostratified columnar ciliated epithelium. In case of smoking and the prolonged irritation by the chemicals of smoking, the epithelium changes into stratified squamous metaplasia. So this is one example. Another example of metaplasia, the one that occurs in the cervix. We had mucus secreting in the cervical cells that with chronic irritation change to stratified squamous epithelium. So this change is called metaplasia in response to chronic irritation. Yes. We come to the pigment deposition in the tissues. What are the types of pigment in the body? What we have, the one in the bilirubin, in case there is obstructive jaundice, you'll start to notice that there is yellowish discoloration of the skin as well as the sclera. This is one pigment. The other pigment is the one present in our skin. This is the melanin pigment. And pathological pigmentation, in concerning the melanin, we have situations of increased pigmentation and situations of decreased pigmentation. And increased pigmentation we all encounter in case of asthma or the pregnancy, where we have increased pigmentation. Decrease in pigmentation is seen in cases of vitiligo, for example. Or we can have tumors arising from the melanocytes. Another pigment present in the body is the lipochrome pigment. This is present in carrots and we eat it. It is present in the corpus luteum. It is present in the seminal vesicles. It is present in the adrenal cortex. And sometimes this pigment deposits in the heart in old age, what we call brown atrophy of the heart. From where it came in old age? It is coming from the wear and tear of the cells. It is deposited in the cardiac muscle, and the cardiac muscle is the heart is small, so we call this brown atrophy of the heart. This is a resume previously on the cell injury. Now we will pass to inflammation. No, خلينا في inflammation. What is inflammation? This is very important. The inflammation is the reaction of a living tissue against an irritant. We stress that it is a reaction of a living tissue. If you got somebody dead and throw a bottle of strong acid or alkali, no response, because it's not a living tissue anymore. So if there is any irritant affecting the body, the response will be in the form of inflammation. What are then the causes of inflammation? As you see from this animation, it can be caused by bacteria, virus, fungi, parasites, radiation, whether the ultraviolet rays or the ionizing radiation, strong acids or alkalis, antigen antibody reactions. All of these can cause inflammation. Examples of inflammation. Inflammation could be localized or diffuse. It depends on the type of the organism. For example, an example of a localized inflammation and separative is what we call furuncle. The furuncle is a small abscess in relation to a hair follicle or a sebaceous gland. And it is considered to be suppurative inflammation. It means that the lesion contains pus. Then we have the traditional abscess. Again, the definition of an abscess is a localized suppurative inflammation. The composition of an abscess is that we have pus, the yellow color, which represents a liquefactive necrosis. And then it is bounded by a pyogenic membrane, and then we have an area of granulation tissue. This is the constituent of abscess anywhere, whether it's under the skin, whether it's an ovarian abscess, whether it's a pelvic abscess, anywhere, this is the composition of an abscess. Next, a brain abscess, for example, again, you will have a cavity, of course, pus is drained, and surrounded by infected granulation tissue. We come to another example of suppurative inflammation is the carbuncle. This is the back of the neck. And as you notice, it's not one abscess, it has multiple openings. So it's considered to be a multilocular abscess, present usually in the back of the neck, especially in diabetic patients. Why is it a multilocular abscess? Because in this area, there is compartments separated by connective tissue. And we get multiple openings discharging pus. The inflammation sometimes is non-suppurative inflammation. Means that we have an exudate, we have inflammation, but no pus. So if the exudate is rich in fibrin, like we see in fibrinous pericarditis, this is an example of non-suppurative inflammation, the fibrinous pericarditis. Other types of non-suppurative inflammation include membranous inflammation, and that is very important in diphtheria, serous inflammation, allergic inflammation, those having allergic rhinitis. These are all examples of non-suppurative inflammation. What if the organism gain access to the circulation? We have certain critical conditions. If the organism itself reaches the blood, this is bacteremia. Anything containing blood, we refer to the suffix -emia. If the toxins reach the blood, as in case of diphtheria, this is toxemia. If we have septic emboli, this is pyemia. Py refers to the septic emboli circulating. The worst of all is septicemia. Septicemia is circulation and multiplication of bacteria and the toxins. It is fatal because it ends by what we call septic shock. And we're going again to mention it when we are discussing shock. What is the vascular phenomena and the local events in inflammation? This again is a seed for MCQ questions. The local events that occur in inflammation are very important. Why it makes it red and hot and swollen? There are certain changes that happen in the wall of the blood vessel in the area having inflammation. We start by the first one is that we get vasodilatation of the arterioles, and we get subsequently local hyperemia, means increased blood flow in this area. Now this will give us two of the cardinal signs of inflammation, which are redness and hotness in the area of inflammation. Then we have next, increase in the capillary permeability. And when the capillaries become wider, they start to leak and fluid comes out. This fluid is rich in protein, and this is what we call the inflammatory exudate. And this fluid, when it comes out, will account one of the important signs of inflammation, which is swelling, and will be accompanied by pain. Why do we do all these changes in the blood vessel? What do you want from it at the end? We want two things at the end of this local response. We want to get this fluid out, which is rich in immunoglobulins. We want to get polymorphs out of the blood stream to the site of inflammation. So the first goal that we get the protein-rich fluid out has been performed. Now we want to extract the leukocytes. The leukocyte, to leave the bloodstream and go out, goes into two steps. The first step is that it will leave the center and go to the margin. So we call this margination of the leukocytes. And then it will go out by a process of amoeboid movement through the capillary wall, and then it will start to phagocytose the organism. I will show you a diagrammatic representation for this. Here we are. As I said, this is the blood flow, and the neutrophils are in the center. So the first step is that they leave the center and marginate here. This is what we call margination. And then they will start in an amoeboid movement to leave between two capillaries. This is called diaphagesis. And then they will go to the organism that is present outside. I will make it more clear by animation. Here we are. See the leukocyte rolling, finding the space, going out to the organism, starting to phagocytose and kill the organism. I want to ask a question. After the leukocyte had gone out, why it walked in this direction? Why not in the opposite direction? Exactly. The directional movement of leukocyte toward the organism is called chemotaxis. As if here there is a magnet that attracted the leukocyte out. This is called chemotaxis. And in this aspect, the organisms vary. Some organisms are strongly chemotactic to polymorphs, and others are weakly chemotactic to polymorphs. So you understood now the steps, how the leukocyte came up. Now what's the function of leukocyte now in inflammation? What do you think the leukocyte has performed? Its function is ingestion, digestion, and even disposal at the end of unwanted material. This is the role of the leukocyte. Again, I repeat, the cardinal signs of inflammation. These are seeds of important MCQ questions. Redness, hotness, swelling, and pain. If you don't find these cardinal signs, then this is not inflammation. It could be a tumor, it could be anything else, not inflammation. What's the difference between acute inflammation and chronic inflammation? A hell of a difference. First of all, the vascular phenomenon that we have just explained to you is very clear in acute inflammation. It is not that clear in chronic inflammation, because you will not keep the blood vessel vasodilated 1 year and 2 years with chronic inflammation. But if it is acute inflammation, 1 week duration, yes, there will be a prominent vascular phenomenon. The onset of acute inflammation is usually sudden onset. The onset of chronic inflammation is gradual in its onset. We come to the cellular infiltrate in acute inflammation. This is very important. you will find polymorphs at the very beginning, and then macrophages appear. Why macrophages appear? They constitute this second line of defense that comes late in acute inflammation and then prepare the tissue for healing afterwards. Okay? The stromal changes, you will find edema very clear in acute inflammation, then in chronic. In spite that it will not be severe, but it's still inflammatory edema. We come to chronic inflammation. As I mentioned, the vascular phenomena will not be very clear. The type of inflammatory cells will differ. You will not see polymorphs. We will see plasma cells in chronic inflammation, lymphocytes, eosinophils, and giant cells. The stromal reaction will be in the form of fibrosis in chronic inflammation rather than the edema that you have seen. The question comes, if you see polymorphs within a chronic inflammatory infiltrate, this will be what we call chronic active inflammation. Okay. As I mentioned, the main cells in acute inflammation are the polymorphs with a role in phagocytosis and digestion of the organism, and then comes the macrophages. Late in acute inflammation and proceeding with us to prepare the tissue for healing or repair. I stress again, the cells of acute inflammation have the lymphocytes with the role in the production of gamma interferon and interleukins. We have plasma cells, we have lymphocytes, and an importance also for the activated macrophages that they will produce for us what we call growth factors that now are recently evolving, and we have an important role in tissue healing, عوامل النمو. We have growth factors like platelet-derived growth factor, fibroblast growth factor, epidermal growth factors. All these are important factors that will proceed with us in healing of tissue. We come to chemical mediators in inflammation. The first and the most important appearing is the histamine. It appears in inflammation, start to cause capillary dilatation, and the capillaries start to leak to help us to get out the inflammatory exudates. Besides that, we will get out the leukocytes. Next. Then we have the origin of this histamine is the degranulation of the mast cells, and it's directed here for the vasodilatation. Then we have complement C3A and C5A, an important role in what I have just mentioned, chemotaxis, which means the directional movement of leukocytes towards the site of injury. C3b concerned with phagocytosis. Then we come to the leukotrienes that are released from the damaged tissue. They all help in increasing vascular permeability. This is the effect of the chemotactic agent. And I say this factor is important for chemotaxis. As I said, it increases the affinity, number, and affinity on the receptors on the neutrophils. And come to help us in inflammation, enhance the motility of the cells, and expression of inducible gene, increasing the phagocytosis mediators. Let me shift to the chronic inflammation, what we call granulomas. We usually mention omas in case of tumor, but why we have mentioned here in case of inflammation? What's the definition of a granuloma? Granuloma is a chronic specific inflammation in which the inflammatory cells had formed a tumor-like mass. That's why we call it granuloma. Okay? The types of granulomas, we have infective granulomas, non-infective granulomas, and granulomas of unknown etiology. Infective granulomas, for example, tuberculosis, syphilis, leprosy, actinomycosis, all these are infective granulomas. Non-infective granulomas, like silicosis in the lung, from the ingestion of silica particles, foreign body granulomas, and this will all meet with sutures and so on, and fat necrosis forms a sort of granuloma as well. Granulomas of unknown cause, and the best example for these is the sarcoidosis. And another granuloma of unknown cause is the Crohn's disease that affects an ileocecal lesion. Again, it's a granuloma of unknown cause. What's the structure of a granuloma? The structure of a granuloma, for example, if it is a TB granuloma, secondary TB, there would be caseous necrosis in the center, and we just mentioned what's caseous necrosis, where we have creamy or cheesy material in the center. Next. We have an inner layer of epithelioid cells. What's the origin of an epithelioid cell? And this can be a set of MCQ. An epithelioid cell is originally a histiocyte that has changed in appearance, having a pale pink cytoplasm, and we call it now an epithelioid cell. Then we have a multinucleated giant cell. And then a middle layer of lymphocytes, and the outermost layer will be fibroblasts. This is the structure of a granuloma. Now we have so many giant cells, so many incorporated in many lesions. In case of TB, the giant cell has a characteristic horseshoe appearance, and it's named after Langhans as Langhans giant cell. It is due to fusion of histiocytes to increase phagocytic activity. So that you differentiated from a tumor giant cell, this is due to division of the nuclei. Okay? Next. We come to this granuloma of unknown etiology, sarcoidosis, and I started that MCQ questions coming on sarcoidosis. It's a granuloma. It has similarities with TB, and these similarities are differences from TB. Number one, it's a non-caseating granuloma. Means that you will not see caseation at all in the center. I stress again, it's of unknown etiology. So the granuloma will be composed mainly epithelioid cells and giant cells. No caseation at all. The patient presents by hilar lymph node enlargement, rash appearing, and it's a red rash, so we call it erythema nodosum, and there is hypercalcemia. These are all diagnostic tests for sarcoidosis, and we have a diagnostic test which is a positive heme test. These are the important points we have to know regarding sarcoidosis. This is the micro appearance of sarcoidosis. This is the granuloma, and this is another granuloma. You get the giant cell, the epithelioid cells, and no caseation at all. We come to tuberculosis. This is an infective granuloma. It runs into 3 stages. We have the primary tuberculosis of the lungs. And when we say the primary complex, there is a triad of the Goins focus in the lung, the TB lymphangitis, and the TB lymphadenitis. This is the childhood type of tuberculosis. Next. And we see here, this is a bones focus in the lung, and usually 90% carries a good fate with healing by fibrosis. Then we come to the secondary TB, or the adulthood type of TB. It's more or less a cavitary lesion in the lung. This is TB affecting the mesentery, in the mesenteric lymph nodes, where they are enlarged and matted together. The worst of the TB is what we call acute tuberculosis. Acute not because it is a short course, because it is rapidly fatal, where we have a TB focus opening to the blood and disseminating the infection on through. So we get what we call miliary tuberculosis. We call it miliary tuberculosis because the lesion is of a millet seed size, 1 to 2 millimeters, and spread all over the organ. Now we shift to syphilis. As we know, it's an infective granuloma, sexually transmitted, one of the venereal diseases. And of course, you know why we call them venereal diseases, isn't it? Why? After Venus, which is the god of love. Yes. Now, spirochetes, the Tritonema pallidum, and syphilis passes into 3 stages. We have the primary syphilis, and the infection here 2 to 6 weeks. The lesion starts 2 to 6 weeks after the infection. The main lesion is the chancre. The secondary stage of syphilis, 2 to 6 months, we start to have rash in the palms of the soles, maculopapular rash, lymph node enlargement, pain in the bones, and with the tertiary stage, 2 to 6 years, up to 20 years of infection, we get the affection in the cardiovascular system as well as in the central nervous system. In the cardiovascular system, this will be in the form of aortic insufficiency and aortic aneurysm, and affection of the central nervous system will end the patient with dementia and tabes dorsalis. Mind you that we have the characteristic localized syphilitic reaction in the tertiary stage is what we call the gamma. It's a tumor-like mass, this gamma. It can be present in the nose, in the hard palate, in the liver, in the testis, and it represents a localized syphilitic reaction. Another diagram for syphilis, differentiating between the primary, the secondary with the rash present, and the tertiary affection after 6 to 20 years, where the patient has forgot what he had done when he was young. Next, please. Then we come to the, focus a bit on the tertiary syphilis. Next. We get alopecia, loss of hair, and as I mentioned, the neurosyphilis, tabes dorsalis, dementia, and paresis, and cardiovascular affection. Here we are. This is a picture of an aneurysm. It usually takes the ascending or part of the descending aorta. This is characteristic of the syphilitic aneurysm. Next. Then we come to congenital syphilis. Congenital syphilis, where we get the spirochete transmitted from the mother to the fetus. It occurs in the secondary and the tertiary stage of syphilis.
Tertiary stage of the syphilis, congenital syphilis can be transmitted.
Secondary and tertiary stage. The possibilities is that we yes, then stillbirth, abortion. We can get structural changes if this baby is born. There are certain changes that occur in this baby. The characteristic changes that can occur is the Hutchinson teeth, where we get notching in the teeth. They are separated. We can have gamma in organs. This is the defected molar teeth. Next. We can have enlarged liver, as I mentioned. We have enlarged spleen, petechiae, skin rashes in this baby who was born alive. Then we come hint on the leprosy. Again, it's an infective granuloma. It's caused by Mycobacterium leprae. We have 2 types of leprosy. We have the tuberculoid leprosy because of the similarity to the TB, and we have the lepromatous leprosy, where we have lots of organisms in the lesion. The face is deformed, nodular masses and sometimes they call it the leonine facies, characteristic of lepromatous leprosy. Now we shift, after all this inflammation, how can we heal these tissues? The healing and the repair. How can we heal an abscess? How can we heal a skin lesion? How can we heal whatever type of tissue damage? So the definition of healing is repair or damage, repair of any damaged tissue. This repair depends on the type of the cell damage. Not all the cells will heal in the same way. We have three types of cells in the body. We have the labile cells. They have a short lifespan and they fall and repair continuously, like those of the skin. We have the permanent cells. On the contrary, if they are damaged, they do not degenerate again. So you don't have except fibrous tissue. And the best example is in the brain and the heart. They are permanent cells. Then we have the stable cells. They are in between. That normally they do not divide or regenerate, but when injured, they will regenerate. And this, for example, like the liver cells, the renal tubules are capable also of regeneration. So the type of healing that we're going to have in the body, either healing by regeneration, one occurs in the skin, either healing by organization, we're going to use big amount of granulation tissue and fibroblasts, or healing by resolution. The inflammation will disappear as if nothing has happened. And in resolution, for example, like lobar pneumonia, we get complete resolution of this inflammation. What's the difference when we say healing by regeneration and healing by organization? Healing by regeneration, as I mentioned, the damaged tissue is replaced by the same type of tissue. The epidermis, for example, heals in this way. The liver cells, if injured, will heal by regeneration. We've got the cells from the adjacent liver cells that will cover the area of damage. Healing by organization, for example, an abscess cavity. Fibrinous inflammation can heal by resolution. If not, it will heal by organization. If we have myocardial infarction, this will heal by organization. It means fibrous tissue deposition. Then what's the difference in the wound healing? Now we concentrate on wound healing. The difference between primary union or healing by primary intention and healing by secondary intention. Now healing by primary intention, this occurs typically in a clean-cut surgical wound without a big scar, and the edges of the wound are opposed neatly, opposite. In case of secondary intention, here we will have a big scar. Either we have a big defect, we had a foreign body, the edges were not opposite, or we had infection and gapping. So, situation with primary union, clear-cut wound, no gap, no infection, no foreign body present in the wound. The stages of wound healing, we have an initial response with the initial appearance of polymorph nuclear leukocytes. They appear early, phagocytose any foreign particle, and then immediately the macrophage will come, and then we start to have later on the fibroblasts. Then we get contraction of the wound by the action of the myofibroblast, getting it smaller in size. The function of the fibroblasts in the wound that they lay the proteoglycans, they lay the ground substance that will help us to heal this area. Next. You have a wound here. I'm concentrating on what is granulation tissue, because we hear this word frequently and we don't know what's the composition of granulation tissue. Three important things. First of all, we have new blood vessels. From where did we get the new blood vessels? We get them from budding from adjacent blood vessels. So we get new blood vessels, we get fibroblasts, and their function is to lay down collagen, and macrophages. Once the fibroblasts finish the work and lay down collagen, we don't need any of these blood vessels anymore, and gradually the granulation tissue will become changed to fibrous tissue. What is the appearance of granulation tissue? How does it look like? Say you see a wound the third day of the operation. How does it look like? I will show it to you next. Yes. Here is the granulation tissue. As I mentioned, new vascularization, fibroblasts laying down collagen. So by second or third day, you will have an area appearing red, granular. If you touch it, it can bleed easily because these are newly formed capillaries. Afterwards, the capillaries become closed and the condition changes into fibrous tissue. Yes. These are the growth factors that when we mention the chemical mediators, and they are important in wound healing, we have the epidermal growth factor, platelet-derived growth factor, keratinocyte growth factor, and even insulin-like growth factor in the process of wound healing. So immediately after operation, we have a blood clot, and this will cement the edges getting closer, and then we start to have the blood vessels coming, and the fibroblasts start to have the work and start to lay down collagen, and then the epithelium regenerates afterwards on the surface. In case of secondary union, now this is a big gap, so you need a big amount of fibrous tissue, and it will leave a bigger scar than that healing by primary union. This is the role of the beginning of the neutrophils coming to phagocytose any foreign particles and clear the area before the process of healing. Factors that lead to delayed wound healing, aside for MCQ questions. We have to know the factors that influence the wound healing. Of course, the overall nutrition, the proteins, vitamin deficiencies will delay the wound healing. With obesity, we have poor vascularity. Don't forget diabetes. Those patients who have cortisone treatment. All these factors correlate to poor healing. Of course, with advancing age, we get poor healing than in young age. The presence of infection or foreign body will delay the wound healing. Of course, when you are doing an operation with a black or negro, consider they are higher risk for the development of keloids. The complications of wound healing. What can you face as a complication of wound healing? In case of healing in, for example, healing of an ulcer or whatever, it's not a surgical healing, yes, but in healing of an ulcer or damage to the ureter, we are having fibrous tissue that will contract and narrow area so we can get stricture formation. And this is especially in the healing of ulcers. Again, if we have no regeneration of the epithelium, we've got granulation tissue and no covering epithelium. So we are left with an ulcer at the wound end. Keloid formation, as I mentioned in Negroes, where we have excess fibrous tissue. They do operation and remove this excess keloid. Next. And we have the problem of incisional hernia, especially in wounds in the abdominal wall, are complicated by incisional hernia. The problem of sinus and fistula, and I remind you of a fistula. Is it a tract of infected granulation tissue connecting two hollow organs or the cavity to the outside? Then we come to cicatrization. This is a soldier coming, American soldier coming from Iraq, undergone a burn, and of course you have excess fibrous tissue deposition that will undergo contraction and give us the problem of cicatrization. This is all for the wound healing. Now we shift to the circulatory disturbances. What are the sort of circulatory disturbances that you have? This means that there are a group of situations related to the flow of blood. If it is decreased, it's pathology. If it is decreased, it's pathology. If the blood supply is totally cut, again, this is pathology. Next. The first of all is hemorrhage. Hemorrhage is escape of blood from the cardiovascular system. According to hemorrhage, we classify either external hemorrhage or internal hemorrhage. And for external hemorrhage, the different terminologies, what's the difference between epiteke, purpurate, ecchymosis, and hematoma? Epiteke is a 1 to 2 milli insect bite size. The purpurate rash is about 1 centimeter. Ecchymosis reaching 2 centimeter, like that seen in the boxer's eye. And the hematoma is a bigger area of hemorrhage, giving you a tumor-like mass. So we added the suffix oma at the end. For example, if you can notice these small spots, these are petechial hemorrhages. And if they are massive, we see them in cases dying from septicemia, that I mentioned that they got septic shock. Yes, this is the septicemia that I said. One of the post-mortem features of septicemia is the presence of petechial hemorrhages all over the body. We can also have hemorrhage in hemorrhagic blood diseases and vitamin C deficiencies. We get hemorrhage here in the gingiva. We can have it also with the purpur. Then we come to hyperemia. Hyper means increased, and emia is blood. Is increase in the flow of blood. And this hyperemia may be on the arterial side or in the venous side. The best example of hyperemia in the arterial side is the vascular phenomena of inflammation that we have mentioned. This is a hyperemia in the arterial side. Then we come to the hyperemia on the venous side. For example, we see it in the lung, what we call chronic venous congestion. This is seen in cases of mitral stenosis, very common. And in this case, when we have venous congestion of the lung, they are enlarged, heavy lungs, deep red in color, and the patient with long-standing congestion will complain of hemoptysis. The blood capillary, the alveolar capillaries full of blood, they rupture, and the patient start to cough blood, what we call hemoptysis. This is the alveoli, alveolar capillaries are full of blood, and we find a characteristic brown cell here. This is called the heart failure cell. This is the brown pigment coming from the iron, from the breakdown of the RBCs released. This is called the heart failure cell, characteristic of venous congestion of the lungs. Then we come to the venous congestion of the liver. This is seen in cases of right-sided heart failure. The liver is enlarged, and it has what we call the nutmeg appearance. I wonder if you have ever seen the nutmeg. It has a mottled appearance, brown, it has a brown and yellow areas. We call the liver nutmeg because it has the dark areas of congestion and the pale areas of fatty change. So it is a mottled liver, resembling the nutmeg. And this is the congestion in the liver where the central vein is markedly dilated. Next. We come to thrombosis. This is not a watermelon. This is a blood vessel, and it is full with a thrombus. What's thrombosis then? Thrombosis is the formation of a solid mass inside the cardiovascular system and during life. Because after death, all the blood is clotted. This is called the post-mortem clot. It's not called anymore thrombus. Thrombus should be during life. And the main component is platelets. Then what are these lines? These lines are growing lines of platelets and named after Zan. Z-A-H-N, so they are called the lines of Z. They are present in the thrombus. Again, it's a site of MCQ question, the lines of Z. The types of thrombi formed in the body according to the color. If we have a thrombus that is mainly formed of platelets, we call it pale thrombus. If it is formed in a stagnant blood, slower circulation, above the plates we will have fibrin entangling RBCs, so it is called red thrombus. And sometimes we have a mixed thrombus with pale and red. Means we have platelets and we have fibrin entangling RBCs. Here we are. This is the normal flowing blood, and this is in case we have thrombus. It will form a mass, and it's usually attached to the vessel wall to differentiate it from a clot. Then we come to embolism. What's the difference between a thrombus and an embolus? As we mentioned, a thrombus is a solid mass in the circulation. An embolism is any undissolved material circulating in the blood until it is impacted in a small vessel. This undissolved material could be a fragment of a thrombus, could be air, could be oil, could be tumor emboli. All these lie under the word embolism. So, but the commonest type of emboli are those the detached part of thrombus. The main complication of thrombosis is that it's fragile. It detaches and leads to thus smaller particles called thrombotic emboli. They circulate in the blood. Say they are impacted in the renal, they will make infarction. Impacted in the mesenteric, they will make infarction whenever they are set. The commonest type of emboli are the detached part of the thrombus. This is what we call thrombotic emboli. They circulate until they are impacted in a vessel wall smaller than its diameter. Next. Here we are. This is the organ where we had an embolus and we had a pale area of infarction due to the fact that the embolus has cut the blood supply to this organ. What if the thrombus is loaded with organisms? So the resulting embolus will also have organisms. This is what we call the septic emboli. And the best example here in puerperal sepsis, where we have septic thrombophlebitis and circulating septic emboli. What is the effect of a septic embolus? Will it do infarction? No, it will do what we call pyemic abscess. Pyemic abscess. A thrombotic emboli that has no organism will cause infarction, but the septic thrombus will be fragmented to septic emboli that cause pyemic abscess. Another important type of embolism is the tumor emboli, where a primary tumor detaches smaller fragments that deposit in an organ like the lung and cause metastasis. Then we get the air embolism. Is any bubble of air, that is, any bubble of air entering the circulation will cause embolism? What is the amount of air that is serious and can cause embolism? It's the amount of air that can divide the blood column into two. ليفصل الكولوم بتاع الدم إلى two columns. This is serious. And when this air will reach the heart, interfere with the myocardial contraction and lead to shock. So it could be a complication of operations, like for example the artificial pneumothorax, the tubal insufflation. We have another situation in the air embolism is what we call the decompression sickness, where the divers go deep and come up very quickly. They should come slowly. When they come up quickly, the nitrogen dissolved in the blood will separate as bubbles and go and make air embolism. Another example that you will face in gynecology, hope not, is the amniotic fluid embolism, where during labor, amniotic fluid and some of this conated fetal cells enter the maternal circulation. Now they enter the maternal circulation, circulate, and can reach the lung and have this effect. If this lung is devitalized, like having CBC, there will be infarction. What is more serious than that is the problem of disseminated intravascular coagulopathy. This is fatal, where we get thousands of intravascular microclots. They consume all the platelets and the fibrin, and the patient bleeds to death. It's because the amniotic fluid has a thromboplastin-like action that causes microclots all over the circulation. And this is definitely serious. Then we have the fat embolism, and this is a complication usually of extensive fractures. And from the bone marrow, you know that the bone marrow is rich in fat, these fat droplets will enter the circulation, become mixed with blood, and impact in a smaller vessel. Then we come to ischemia. We took hyperemia, increased flow. Ischemia is a decrease in the blood flow. We can have partial ischemia, and this occurs mainly in atherosclerosis and is manifested in cases of angina pectoris. Here we are. This is a vessel having atherosclerosis. This is the normal lumen, allowing good amount of blood flow. And see in atherosclerosis, this is the lipid deposition, and see how much the lumen of the vessel is reduced up to 70%, that resulting in ischemia. What's the difference when we say ischemia and infarction? Infarction is complete cut of blood supply. Again, side for MCQ questions. Complete cut of blood supply, the resulting area damaged either will have a pale color than the surrounding, so we call this pale or white infarct, or it will have deeper color than the surrounding, so we call this red infarct. The pale infarct is seen in the heart, in the kidney, in the spleen, where the dead area has a paler color, while in the lung, because it's well vascularized, as well as in the intestine, the dead area will have a darker color. So we call it red or hemorrhagic infarction. So this is an example of myocardial infarction. It is usually when the myocardial is infarcted, it's a pale or white type of infarction. We come to worst of all is gangrene. What's the difference between, I say, this is necrosis and this is gangrene? For gangrene to occur, we should have two conditions: necrosis and putrefaction. The necrosis is due to cut of blood supply, and putrefaction is caused by putrefactive organisms. The major two types of gangrene are the organs of the limbs. We have the dry gangrene of the limb. As the name shows, we don't have edema. The condition is dry. It's related to the old age caused by atherosclerosis with gradual decrease in the blood supply. The black colors start to appear. The process spreads slowly until it finds an area of adequate blood supply, and we get a line of demarcation separating the dead area from the healthy area. The next type is the moist gangrene of the foot. This is very serious, especially in diabetic food, where the gangrene spreads very rapidly. Toxemia is very marked. We don't get line of demarcation. The offensive odor is at its maximum. These are the important points regarding the moist gangrene: bad prognosis, maximum putrefaction, and no line of demarcation. Then we come to edema, and I shifted edema here with the circulatory disturbance, in spite of the notes you have it with inflammation. Edema means excess interstitial fluid. And this can be either in the interstitial spaces or in the serous sacs or in the pulmonary alveoli, and we get pulmonary edema. Next. What are the causes of edema? For the normal circulation of interstitial fluid, we have fluid coming out from the arterial side, and then it's absorbed in the venous side, and then some will go through the lymphatics. So when can we get edema? The easiest, if we have lymphatic obstruction. This will lead to edema. If we have here decrease in the proteins, in the plasma proteins, this will decrease the osmotic pressure, and so fluid will go out. Or if we have arterial obstruction here, so the fluid will come out and will not be able to go back again. This is another type of edema. We have edema with inflammation. And what's the cause of edema of inflammation? Is the vasodilatation that we have made with the help of the histamine and the other vasoactive amines. So if you compare the fallopian tube here with that having an inflammation. To say this is inflammatory edema, you should see inflammatory cells. Otherwise, it's not an inflammatory edema. Then we have edema due to heart failure. And in this case, is it a transudate or an exudate? If it is due to heart failure, it will be transudate. And the word transudate means that you will have three things low. Low protein, low specific gravity, and low cellular content. Next. Edema of the heart failure begins in the dependent areas, in the foot and the ankle, and goes out. It is pitting edema. Then we have edema due to loss of proteins, and this is related to kidney diseases, where we have what we call protein losing kidneys in nephrotic syndrome, where we have heavy proteinuria. As a result, we have a decrease in the osmotic pressure of plasma proteins, and the patient gets the characteristic edema of nephrotic syndrome. You correct this kidney lesion, everything will go back perfect. Then we have the nutritional edema, where we have a state of hypoproteinemia. Again, there is decrease in the osmotic pressure of plasma proteins. So we have this child having kwashiorkor, we have edema due to hypoalbuminemia, anemia, we have fatty liver, we have venous atrophy in the small intestine. Sometimes we get the edema fluid mixed with blood and accumulating in the serous sac, for example, like hemopericardium. Here the fluid is hemorrhagic, full of RBCs. This is can be seen in hemothorax and in hemopericardium and even hemopericardium. Then we come to the non-pitting edema. Why in elephantiasis it's a non-pitting edema? Because when you press here, it's not only fluid. When you press, there is lymph and excess fibrous tissue proliferation under the skin. So when you put your finger, it will not be displaced. And so the edema in elephantiasis is non-pitting. When else when we can get lymphatic edema? After mastectomy, with the removal of the draining lymph nodes, we get lymphedema of the arm. So it's not always lymphatic obstruction with elephantiasis, we have it with the after radical mastectomy. Then we come to shock. As you see, the patient will not ever knock your door, he will be coming by ambulance. It is a state of acute circulatory failure due to inadequate flow of blood to the tissues. What are the causes of shock? The first one is the hypovolemic shock. The hypovolemic shock is due to loss of blood. The loss of blood could be the source of external hemorrhage, could be dehydration, and this is commonly seen in infants, or could due to external loss of fluids like the extensive burns, internal hemorrhage. All these can cause hypovolemic shock. Here we are. This is an example of a dehydrated child, and this is an example of burns. Both of them can lead to hypovolemic shock. Then we have cardiogenic shock. The blood volume is normal, but we got an extensive myocardial infarction. A big area of the cardiac muscle is dead, no cardiac contraction, and we get shock. Or we can have massive pulmonary embolism or hemopericardium. If we get excess accumulation of fluid in the pericardium, it can stop the movement of the heart at the moment, what we call cardiac tamponade. Then we get the septic shock that we mentioned with septicemia, and pass through all the effects of septicemia is that we get massive adrenal hemorrhage. This is the Waterhouse-Friderichsen syndrome. We get the blood is fluid, no post-mortem clot is formed due to the excessive hemolysis of the RBCs. The spleen is enlarged and is easily washed under tap water beside petechial hemorrhages all over the body. This is the typical post-mortem picture in septicemia. Again, with septicemia, we get fibrinous inflammation on the pericardium and the pleura and so on from the toxins circulating in the blood. This is the toxic shock syndrome. So we get these wide areas of hemorrhages complicating septicemia and other types of shock. We have, as I mentioned, the septic shock. We have those related to poisons and drugs, like the snake venom, for example, causes shock. And then we have the neurogenic shock, or what we call the vasovagal attack. Definitely we have passed with it once. When you see blood, when you see, when they're put under stress, severe pain, mechanical injury, this will cause the patient to collapse in a second from vasovagal stimulation. Then we come to the effect of radiation, which is becoming very important now, and again, side for MCQ questions. What would be the effect of radiation? We are starting with the environmental and nutritional pathology. We come to the ionizing radiation. It has effects starting from the effects after 2 seconds up to the effect along the years. The radiation damage will have breaks in the DNA, and after a little bit time, you start to have affection of the gene expression changes, and later on we will start to have cell death, and this can be in an acute form, and we start to have genomic instability. This would be manifested in the form of development of cancers, birth defects that would appear later on. So this is the DNA, and exposure of the DNA to ionizing radiation will start to have a deformed cell, a defect in the DNA that will give us a cancer cell. And I said sliding we were stopped at the effect of irradiation, and ممكن it starts immediately a few seconds after and can extend even up to years, starting with radiation damage to the breaks in the DNA. Then we have affection of the gene expression, with gene expression that afterwards will be reflected in the form of cancers and birth defects, and we will start to have cell death. When in mild cell death, the extensive radiation necrosis. Next, as I said, cancer is a multi-step procedure. So, we subject this quiescent cell للميوتيشنز بتاعت الionizing radiation. We will start to have what we call an initiated cell, خلية محفزة, and later on this will change to cancer cell. The mechanism of injury after exposure to irradiation. Next. Either, as I mentioned, direct injury, and this will make breaks in the DNA with its genetic effect later on. The indirect effect under renal ionizing radiation will cause radiolysis of water. We all know water is H2O. لما هيحصل فيه radiolysis of water, we will get free oxygen radicals, and these itself cause DNA affection and produce mutations in the cells. The overall effects of irradiation, we get arterial thickening, mutation to the fetuses exposed in utero. We will get bone marrow hypoplasia. Know the bone marrow, how it is a busy factory for production of blood elements. Rash and affection for the skin, بنسميها radiation dermatitis. Radiation pneumonitis with inflammation in the lung of alveoli. And the next question comes, what are the cancers induced by irradiation? Not any cancer we implicate irradiation. في certain cancers associated مع irradiation, leukemias and lymphomas, breast cancer, thyroid, الناس اللي بتاخد ionizing radiation, lung, and osteosarcoma of bone. We come to the effect on the pregnant mother and irradiation. Next. The rapidly proliferating tissue, the differentiating tissue are very sensitive. And I give you an example. If you get one who is walking and one who is running and put a piece of rock here and a piece of rock here, who will be damaged easily? The one walking slowly or the one who is running? لو حطيت قدام الرانينج ده طوبة، مين اللي هيتكعبل؟ اللي ماشي بشويش وحطيت قدامه طوبة يتكعبل أسرع ولا اللي بيجري ويتكعبل أسرع؟ The one who's running is the one who will be damaged. So the rapidly proliferating cells and the differentiating tissues are more sensitive to the radiation damage. So they can cause in the fetus developmental problems, particularly in the developing brain, if the embryo of the fetus is exposed prenatally.
Excuse me, what is the dose?
I wrote you the doses, but actually I didn't get it on the slides. I wrote it in the reds. Okay? Then we come to the developmental conditions. Other conditions is that the baby can have low birth weight babies, microcephaly, mental retardation, and neurological problems. Next. Next. We come to, sometimes we use radiation and the tumor is sensitive, what we call radio-sensitive tumors, and other tumors are radio-resistant. So don't expose him to radiation for the treatment and he will not respond to this treatment. For example, in the high sensitive cells, they tend to divide a lot, like the lymphomas, and in the gonads, like seminoma. This is a repetition. Slide اللي بعدها. We mentioned the radiation pneumonitis. Next slide, please. We come to the part of the nutritional pathology, and this is a part for MCQ again. Aside for MCQ, despite you consider it easy, but we get a lot of questions on this part. We come first to the nutritional problems related to the protein calorie malnutrition, like marasmus, where we get wasting, sort of atrophy, and the small weight baby. We mentioned before the kwashiorkor, it's an advanced stage where we have hypoproteinemia, marked decrease in the intake of the protein, characterized by the edema, fatty liver, anemia, and the characteristic hair, what we call the flag sign. ناعم وبيطير بسهولة. This is characteristic of kwashiorkor. Then we come to vitamin B1, which is present in the fortified breads, the fish, and the cereals, and so on. Yes. Now, its deficiency, we get the beriberi, where we have vernix encephalopathy, we get wrist drop, We get affection in the brain. We get affection of the reflexes. Beriberi could be of a dry type or a wet type. Wet beriberi refers to the presence of associating edema. Next. Then we come to vitamin B2 deficiency, where we get glossitis. Glossitis is inflammation in the tongue. We refer here to the Latin word of the tongue, which is glosso, so we call glossitis, and we get dermatitis as well. Whereas in vitamin C deficiency, we get looseness of the teeth. This is due to inflammation of the gingiva, gingivitis, as well as small hemorrhages due to lack of support of the blood vessels. Next. We come to the vitamin B12 and the megaloblastic anemia. Of course, we know for vitamin B12 absorption, we need the help of the intrinsic factor, and then we get here ileal absorption. So the situations that we can have vitamin B12 deficiency, either there is decreased intake or in cases of malabsorption, where we don't have absorption of this vitamin B12, the resulting effect is that we get the megaloblastic anemia. Besides, we have again glossitis, inflammation of the tongue, and we have an important lesion which is subacute combined degeneration of the spinal cord. Next. Then we come to the vitamin A deficiency, and we'll start by the possibility of the night blindness, opacity in the cornea, keratomalacia, susceptibility to bronchopneumonia, urinary tract infection, and keratosis in the skin. Next. Then we have the problem of rickets and vitamin D and osteomalacia. The child having rickets, starting from the head, we have bossing of the head, delayed closure in the fontanelles, a pot-belly abdomen due to weakness of the abdominal muscles, and we have bow legs. This is because in rickets we put osteoid, and this osteoid is inadequately mineralized. The steps of bone formation takes 2 steps. To form a bone, you have to put osteoid, and then the osteoid should be mineralized. In case of rickets, we have put the osteoid, but it is not adequately mineralized. As a result, the epiphyseal end will be broad, but it is weak. So, by the weight of the baby, on the legs will start to be bow legs. Now, in case of females, after repeated pregnancy without support or supplementation with calcium, yes. Okay, thank you very much. Lack of supplementation of calcium in females, we will start to have osteomalacia. You will not find all these changes because the epiphyseal plate is formed. But the patient will complain of bone aches and liability for pathological fracture because the bone is inadequately mineralized. Next. We come to another side for questions, which is the iron deficiency anemia and the microcytic hypochromic anemia. Very common in females. This is due to low intake, and we all know that in case of iron deficiency anemia, get easy fatigability, dizziness, weakness, and a characteristic finding in the nail bed, what we call spooning of the nail or koilonychia. Koilo is anything related to the, it's a Latin word, no, I will not go into its meaning. Anyhow, it's a spoon-shaped nail. The opposite of this spooning is another feature in the nail bed called clubbing. The clubbing heel hypertrophy, while spooning, it is concave nail bed, characteristic of iron deficiency anemia. Next. We come to the adverse drug reaction and their effect. And on the top of these, we will concentrate on the use of the cytotoxic drugs and the chemotherapeutic agents with their effects. Of course,
Here, for example, the schedule concentrated on the ocular adverse effects of the drug. Let's concentrate on the methotrexate and tamoxifen. Most of these drugs cause conjunctivitis, blurring of vision, photophobia. With tamoxifen, there is the susceptibility of optic neuritis and retinopathy. Apart from the ocular complications of these drugs, let me add a word on the tamoxifen, that with the long use of tamoxifen, there is a liability of a development of an endometrial polyp, characteristic with those receiving tamoxifen. Other side effects for cytotoxic drugs, and they share it in common, that we have a liability for the mildest is the nausea and vomiting, immunosuppression, nephrotoxicity, hair loss, mouth sores, cardiotoxicity and hepatotoxicity, and besides memory loss. Now we come to an important topic. This you cannot exclude an MCQ exam without asking about tumors. What is a tumor? The tumor is a new growth of unlimited multiplication of cells that serves no function to the body, and it's not under the control of the body. We have just taken in the beginning the wound that has a gap. We form a new tissue called granulation tissue. Did you consider granulation tissue tumor? No, it's a new growth, but it's not a tumor. Why? It has a function, and it's under our control. Once you fill this cavity, stop growth. Therefore, this is a controlled growth. We will all infants, and we are grown-ups. Do we have tumors? No, because our growth has control and has a function. But in case in tumor, we don't have a function and we don't have a control. Okay? Now, to classify tumor, this is a big issue, but the most important of them is to define whether this tumor is benign or malignant tumor. What are the characters that tell you that this tumor is a benign tumor? First of all, most benign tumors have a capsule. I say most because some do not have a capsule. For example, a papilloma doesn't have a capsule, in spite that it is a benign tumor. A hemangioma doesn't have a capsule. Okay? And the tumor is very well differentiated. You will hear a lot the word differentiated. What does differentiated mean? The differentiation